Welcome back to Physioplata. I'm your host, Rod Henderson. This is my co-host, Dr. Patrick Damreth. And we're here today to talk about shoulders.
Shoulders.
Yeah. And before we get into shoulders, because there's a lot to talk about, we got a couple, had a few interesting injuries that have popped up. And so I wanted to talk a little bit about what you're doing at your gym right now and some of the things we're doing at our gym.
Wait, you had some injuries pop up?
Yeah.
You did?
Yeah, got a guy, it wasn't this week, it was a couple weeks ago. Actually, it was maybe a little bit longer than that. But had a torn pec.
Oh, no.
Yeah.
Dude, let me tell you a story.
Right.
So I've got a story about that, and it was really interesting and very unfortunate because it's one of those freak things. Like, it's not a very common thing that happens,
No, it is not.
but when it happens, it sucks really bad. But it does happen in jiu-jitsu more so than other sports that I can remember. Obviously, I haven't looked into like the statistics or anything like that. But yeah, man, it's weird because sometimes the way it happened to somebody that I have encountered was not very traumatic. Like, it wasn't like a super huge movement because, you know, usually I hear people getting their pec torn from an arm bar most of the time is I think what I've heard the most.
That's what happened in this case.
That's what happened in this case.
Yeah.
And I mean, I can see it. Like, if you're really like in a compromised state and you're just muscling through, trying to hold on with the finger strength that you have left, and then, you know, you rip it and then your arm gets extended, abducted, shoulder is being pushed forward. I can see that. The one that I was encountering on my end was from trying to get to a back control, already having the legs in, like the hooks in.
Yeah.
Then I was cupping the shoulder, and this individual, this friend, unfortunately, like muscle through it, tried to turn the opposite direction. So I was
against
just
your hook.
against my hook on the shoulder. So it was not the long lever of the extended arm.
Turning away from it.
And that was very mind-blowing to me because I would have never thought that something like that could have happened. And there's always some, you know, factors that you have to take into consideration, like the dogs.
It's okay, we'll get him to stop. The dogs will calm down here shortly, I promise.
Well, anyway, so it so it was just a short lever, and I always thought, like, if you tear your pec, you're gonna do flies with weights and the armbar fully extended, you know, stuff like that. But so I was like very surprised about the fact that a short lever trunk rotation can cause the pec to tear. And what I was going to say is, like, you never know the underlying factor. There might be some genetic factors with laxity or excessive flexibility. There's maybe a nutritional factor that you're having to take into consideration, overtraining, stuff like that, previous injuries, right? But that was very interesting. I didn't think that was going to happen like that. And I thought it was a shoulder dislocation. Yeah. Because it was like the suction cap. It was like this pulling, and then pop, and then it was like this guy just dislocated his shoulder. Yeah. And I was just trying to, you know how you're like trying to figure it out as it happens, you know, and that's like really challenging on the mats, doing it right there and then. And I was like, man, this shoulder dislocation doesn't seem to be going back in. And usually, you know, you do a little traction, abduction, and you can get the joint to relocate. And this is interesting because nothing happened. All I could feel is just this huge muscle guarding. Like, I really felt like, man, this guy is just not letting go. He's just protecting his shoulder too much. I can't get it in because he's guarding so much. And I've, you know, learned like over the time that when people are guarding like that, you shouldn't be forcing it, trying to get that shoulder relocated. So I was like, look, you might need some anesthetics for them to put that back in. And I was just so set on him having this dislocation.
You were convinced
I was convinced because it was like by his side, it was like a little bit depressed, and it was like really like the muscle bulk on the front.
He completely ruptured it? Or it was
I think I don't know the whole extent of the story afterwards, but it was a torn pec and actually then instead of a dislocated shoulder. So that was my experience with that.
Yeah, that I wasn't there with this guy named Brandon. Brandon, I hope your recovery's going well. I bet it is.
Shout out to Brandon. Hang in there, man.
Yeah, you're going to be getting through this. But he had surgery. He had a pretty significant rupture, and it was just resisting an armbar. You know, and just tweaked it just the wrong way, and ended up. It was pretty obvious right off the bat what was going on, and You know, it's a good 6 to 8 month recovery after you've had surgery.
The pec pec is major.
Yeah, pec is major, man. It's major. So it's a great joke. But the recovery that he's going through, he's doing very, very well. And so I fully expect. He just got his blue belt. So he got his blue belt, and like 2 weeks later he tears his pec, so he's gonna have to sit.
So what do you think happened? What do you think happened? What's like the size disproportion between him and his opponents? Like what's going on there?
I don't think there's a big size. I think it was. Look, and I've said this many, many times. If we could really figure out what contributes to injuries with any regularity, with any validity, Kobe Bryant never would have torn his Achilles. You know what I'm saying? I think it's
R.I.P.
Yeah. R.I.P. to Kobe. But it's very difficult to predict some injuries.
Yeah, that's true.
I think there's some times where you can say, okay, there's some fault lines that you can see emerge. So if you have somebody who's a very big runner, for example, they're running and they're overweight. Well, the fact that they're overweight can contribute to some lower extremity issues.
But you can't say because you're overweight you're injuring your leg.
That's right. It's just like a contributing factor. And so with Brandon, in his case, I didn't see any contributing factors there. I think it was just a fluky injury.
Do you think fatigue level was a factor?
It can be, but man, I just don't know. I don't know how fatigued he was when this happened. He told me the story about it. So it's just a tough deal. I think looking back on an injury and then trying to figure out what contributed to it is always, I think it's a fool's errand. I'm not a big fan of trying to reverse engineer why you got injured. To me, at least from my peace of mind, it's like, okay, you have the injury, let's move forward.
Sure.
And if we identify things that might predispose you to continue to have the same problem down the road, yeah, we address that. But going back and going, oh, well, you were tired, you have an asymmetry and this and that. And I think it's at least for me, over years of practice, I found it to be not the best use of my time with patient. So
I get that. I agree with that. I will be the one to tell you though. I do reverse engineer a little bit, and I don't go out and say, "Hey, this is because you've injured yourself." Because I don't. Any healthcare professional that tells you you've injured yourself because of this and that is overconfident, in my opinion. And you never know like exactly what had happened, because you can't always look on the inside of someone's body, and there is something so minute, like micro tearing in this muscle or in that ligament, that you just can't make assumptions like that. But I will go back and say, look, these factors right here are highly suspicious, and I would consider them to be contributors or precursors to this type of problem. I'll go out and say that, and I'll say, I don't know if this is exactly what happened, but this can definitely predispose you to having something happen again. Yeah. So let's work on that in addition to moving on forward and getting, out of that problem that they're experiencing right now.
Yeah. I think a certain amount of doing that is helpful, and a lot of our patients, I think it's when something happens and it's traumatic and it's a bad injury, one of the first things that you get to after you get over the initial shock of having the injury is, why did this happen? And so having an explanation of why it happened is a good conversation to have with people. And I try to have it insofar as I can safely make that connection with what kind of problem they were having before to this injury. But the connections are sometimes kind of loose.
Sure.
So I always try to make sure we don't really know.
Yeah.
Sometimes it's hard. Sometimes you're driving down the street and, you get in an automobile accident and you're like, well, why did this happen? Well, sometimes you could be doing everything right and you could still have an accident.
Yeah, that's true.
But yeah. So, we're trying to keep everybody healthy at our gym. Everybody staying healthy at your gym?
Minor aches and pains, like nothing major. I'll say that much, knock on wood. Yeah. But so far, as far as I know in my vicinity where I'm at, I haven't heard of anyone getting injured, but there's smaller things and that's what I appreciate, because people come to me when there's smaller things and they reach out and say, look, I've got this problem. Do I need to worry about it? Do I need to do something about it right now? Is this going to resolve on its own? And I'm happy about that, because that helps me to be, present in that community, of course, with all those athletes, and I can let them know when there's something getting out of hand. So there's always something most of the time where I'm saying, look, this is something you should be worried about, or this is something you should pay attention to. And when you're feeling this and that, you might want to work on this certain muscle group or whatever, or you're lacking hip internal rotation, you should be working on hip internal rotation, and they can venture out and look into what they need to do for that. And then if things are getting a little bit worse, which unfortunately sometimes they do, right? And it's not always just because of jiu-jitsu. Sometimes it's also because of other factors like work and whatever that happen. Because a lot of, I don't know about what the percentage is, but there's a lot of jiu-jitsu people or athletes who train jiu-jitsu who are doing heavy manual labor too. Like they work, there's a lot of plants out here. So people will be working as contractors and whatnot, and they're like, they're using that machine, man. Totally. Yeah. So, and it's like something like that sometimes. So if things do get worse and continue to go downhill, they do reach out to me, and I'm thankful for that, because I'm able to most of the time get them back on track and let bigger things stay out of their system. Like that domino effect, usually I'm able to intervene before it gets too bad in that sense.
Because that does seem to happen a lot, right? I mean, you pick up an injury, and then my coach, Coach Lonnie Vickery, shout out Lonnie, he's constantly dealing with some sort of pathology, whether it's shoulder, his hip, his back. And there's a lot of reasons for that. One, he's outside of what he does as our coach, he's he does a lot of manual labor. He works, he's like a construction guy. He does a lot of stuff, working on home remodels and that kind of stuff. So he's constantly wearing his shoulder down. And then then he comes up to the gym and he trains his butt off at the gym. And so it makes it hard. It makes it very difficult to get ahead of the injury that you're dealing with, when it's almost impossible to avoid stressing that area out.
Well, that's interesting that you talk about staying ahead of the injury. And I think that what helps more times than not is a lot of times when I'm finding deficiencies, when people are working with me and I find like certain areas that are breaking down because of certain muscle imbalances or range of motion deficits and stuff like that. If there is an initial positive response to what we're implementing, and it has like the ceiling effect or something like that, or it works a little bit and then it doesn't work as well as it was. What has recently happened is I have this client that I'm working with, he increased the amount of correctives that he's doing, right? So the stuff that I was showing him to work on his muscle imbalances, he started to implement that more frequently during the day, rather than just having one session, a couple minutes here and there that he was doing that stuff. So as he implemented that more frequently, his symptoms then started to come back down again, because the way it went was that he came in with a lot of pain. We implemented X, Y, and Z to help his imbalances and deficits, and he got significantly better, 60% better or so he was saying. And then it tapered off and it didn't get better anymore, but that's because as he felt better, he started doing more again. So he started training again daily instead of just 3 times a week and that stuff. And he increased the amount of exercises he was doing to manage the amount of load he placed on the other muscles group that were causing his imbalances. And then he was able to even it out, and he's back on track and feeling much better again.
Do you think though that maybe some of the stuff that you were doing had because you brought up the fact that his symptoms got better while you were doing these corrective exercises, but he was also during that time not training as much, right? So then he started ramping it back up. And so then there was that point where his and he was ahead, at that point he was ahead of his injury. And as you were working on these issues that you identified in your assessment, and then he started dipping back up. Were you in control over that, him going back into his activities?
No, that was... a self-limiting thing.
Yeah.
So he had a lot of symptoms and decided to reduce his volume on training to manage his symptoms. And then again, he got better, which meant that he was able to implement his normal volume that he was doing before he felt really bad. And then, that's when he had that little dip and then came back up.
For me, that's the biggest challenge, is managing that volume, managing that training load.
Yeah.
Because the exercises themselves, are always, they're fun, and I enjoy the rehab exercise part of it. But then helping people, to me, we were talking about shoulder pathology, getting things better. We're talking about load management. It's such a huge part of that. And
so you're saying like you like to have that periodization a little bit more in check, where you're like focusing on how much people increase or decrease their volume
100%.
rather than.
To me, I think it's the most, at least for me, it's the most important factor, because you see it a lot with runners, but you can also see it with jiu-jitsu practitioners as well. They'll get an injury, and then the guys that'll keep going, they'll keep training, and it's like, oh man, 3 months later, I still got this shoulder thing, I still got this. But then you'll run into people that say, I had this injury, I shut it down for a little while, and then my shoulder started fit. I've had so many friends that have done this where it's like, I quit jiu-jitsu and my body felt instantly better. And I don't like hearing that, but that happens a lot. And
when you say that though, to me, there's too many variables, because jiu-jitsu is just an open ocean. So you're trying to have someone, because we're trying to take someone out of the ocean, essentially. I don't know if this analogy is going to work, but bear with me here. So let me know, man. So here's the thing. I'm trying to take this swimmer, let's say he's a triathlete, right? He's swimming in open water, waves, currents, everything is happening. So that's jiu-jitsu. Okay, I'm trying to take this guy out. I'm going to try to put him in the pool, and I watch him swim. And then I notice he's prematurely turning his thumb in and rotating his shoulder into internal rotation, a closed position, and then he's finishing his stroke. Then I'll fix it in the pool, I fix it, right? We're working on it in the pool where we're trying to make sure that his opposing muscle groups are able to prevent this problem from happening on this isolated incident. And then I'm taking him out of the pool, I'm putting him back into the ocean, into jiu-jitsu, into the open environment. And then I'm saying, okay, look, we've been working on this issue that's been breaking down your form, your stroke. I want you now to take that into the open ocean with the waves, with the currents and everything like that. And I want you to keep it. I want you to continue to using that improved pattern so that you're not reverting back. And then I'm saying, okay, let's control this volume here. Now you're in the open ocean. I want you to swim for 10 minutes instead of your usual 45. And then if that's working well, then we're going to add 10. And we're going to add 10 until you get to 45. But we started by taking you out of that open environment into an isolated environment, closed environment, and we're addressing pieces at a time and then throwing you back in, like an experiment, like throw you back in. Can you do it now? Can you do it now? And that kind of thing, until you get to the point where your issues, your breakdowns are minimized. You
just said the same thing I said, only you just had a much longer.
You said volume.
You said a flowering metaphor. You did the ocean and all the stuff, and then
it sounded better, right? I'm telling you, it sounded
that's
better.
That's fine.
I'm just saying.
You said the same thing I did, only you did it like 10 minutes. I said it in like 30 seconds. Yeah, that's fine.
You said you wanted to control the volume, how much they were swimming, and telling them basically, hey, if you stop swimming for a little bit.
Trying to manage the load, and so.
But I'm trying to manage the movement first. Yeah. I'm trying to say, hey, look, this is what's happening, and then fix it or help it and improve it, and then volume. That's what I'm saying. I'm saying is like do this first and then the volume.
I feel like we're saying the same thing.
Okay,
I feel like we're on the same page here. Okay. We might be just saying things a little bit.
Language barrier.
It's not a language barrier.
Language barrier. Anytime I mess up, I'm going to tell you language barrier.
It's not language. We got to get past using this German. This thing with you being German.
No,
it's not a crutch.
Always going to use it.
No, it's just it's just a terrible metaphor.
It's like it's used. It's the way it is.
No, ultimately I do think we're saying the same thing. I mean, trying to manage the individual's load in whatever way we're looking at that load. I mean, you got to pull them out to a degree, and this is the hardest thing I think people have a hard time with. Runners are a great example. We've talked about this before a few times, where it's one of the first things you have to do when you're having a problem that's persistent, it's not getting better, is you got to pull yourself out of the activity to a degree that's giving you the. So in other words, runners are going to have to. You got to make a concession with running intensity or running volume.
When you're having issues, it's not the time to work on a faster time or a longer distance with that activity. You need to revert back a little bit to investigate.
Right.
Yeah.
You got to pull back. You got, and like you said, I think your example of pulling the person out of open water and into a pool where you can, things are a little bit more calm, a little bit more relaxed. You can look at movement better. I think it's a really good example, and I think that's what you're. And so that's what I try to do. I try as much as possible to not red light somebody from an activity.
Yeah, I feel the same way. I'm trying. That's what I was, I guess, trying to say is like I try to touch volume as late as I possibly can because it's received the worst by any athlete most of the time. It's like it's something that's very touchy, and I don't want to have to deal with that unless I absolutely have to deal with that. So I'm going to try all these other measures, which is movement, driven and deficiency driven.
Before you start pulling
Before I pull back, yeah.
Okay.
I'm just saying, don't do more. Don't do more now because you're struggling with what you're doing now. Don't want to increase what you're already having issues with.
Yeah.
So obviously, yes. A general rule of thumb, if you can back it up by 25% or so while you're figuring out what's going on and implementing what you need to implement, I mean, obviously that's what I'm going to recommend. But I typically, especially with jiu-jitsu athletes, have a hard time proposing that. It's just not well received trying to take back training time.
They don't want to back up.
And it's not just jiu-jitsu. I mean, you name it, like runners, basketball players. I mean, it's always usually the same idea. And that's kind of understandable.
They enjoy it.
Yeah,
they enjoy what they're doing. Yeah.
And that's why I don't want to have to do that as a first intervention, so to say. I want to do some other things that I can try to see, if I implement this or that, is that supporting the volume you're doing right now? And if not, then, well, I'm sorry. We're going to have to, dial back a little bit until the ratio has improved.
Dude, that's so interesting because my approach is almost the complete inverse of that, because one of the first things I'll do is say, okay, we're going to pull back and we're going to start seeing what volume you can tolerate.
Yeah.
You know what I'm saying? And so it's very interesting because it gets to the same point, but just through different means. And your way probably is a little bit more palatable to people just because it doesn't offer as much of a, you don't have to shut the
And I don't think, honestly, I would have to say, I don't think we can say either one is better than the other. It just depends, right?
Yeah.
Like everything depends. But that's the reason I'm just saying that I'll touch volume later.
Yeah, no, I like it.
Because I want to see, how much can I impact what you're doing right now. And then if it's not enough, then we'll need to look at additional factors.
Okay. Like
volume for sure.
Fair enough.
But I can see it totally from your perspective too, because sometimes you can say, well, you probably get there faster if you reduce your volume right now. And that is probably most of the time true as well, because if you're cutting back on the volume initially, you don't have this question that has no answer yet as to how much your interventions are impacting that volume, because you have inflammatory factors or other issues with pain that are coming about because of the volume.
Well, this really goes, so we're talking about two different ways to approach a similar problem, and they're both workable. And I think this goes to what we see, or what I've seen a lot over the years, which is not everybody that has an ache or pain goes to see a physical therapist or a doctor. Some people, they navigate this process themselves.
Yeah.
And I don't think that's entirely a bad thing. I think, but if, and we've said this before, if you're having a problem that's not getting better, that's not resolving, despite the fact that you've changed reasonable things within your training program or within your exercise program, that's when it makes sense to take the next step and talk to a healthcare provider that has some background in your activity. So if you're a runner, it helps to have a clinician in your side, in your corner that has a background in running, or at least has enough sympathy for what you're trying to get to. And so what we're doing here, hopefully with this podcast, is say, hey, look, once you've exhausted your means of trying to manage this problem, you reach out to somebody who understands. So there's not a ton of physical therapists that do jiu-jitsu. And so we'd like to be a resource for you. So if you have a question, if you have an issue that you want to discuss or you want to see us discuss more, please feel free to leave a comment so we can maybe drop it in and for a future episode down the road.
Yep.
But definitely reach out to a healthcare provider that can make a difference without getting. And we'll talk about this probably down the road, where you don't want to get wrapped up with a clinician who's just going to sign you up for multiple sessions of care.
I mean, that's, I was just thinking about that as you were talking, and what I was going to say is that if you see a physical therapist, even from PT school to now, what the goal of a physical therapist should be is to put him or herself out of business.
Yes.
That's always been the same. If I start hearing about all this jazz about, I'm seeing this PT 2 times a week for 12 weeks and they want to schedule me for more and this and that. Like, I get it. Like, every situation is like different and you always need to really get the whole full story. But the thing is, like, if you don't get the sense that your PT is trying to get you back to what you're needing to get back to, and trying to do that without having you come in for the end of eternity, then, maybe that's not the right situation for you, because that's always what I'm trying to do is, like, if I can work with people before things start to break down in terms of affecting the whole lower extremity chain, for example, right? You have a knee hip or a hip problem, and then now it's become a back problem and foot problem. Man, that's a lot more work now. I'm lazy. I like if you're coming in for just a small thing and we need to do this and that, A, B, and then, maybe a little of C, rather than having to go down the whole alphabet and have you come in for a long time. So that's what I not only learned in PT school. That's not just how I feel personally, but that's what I believe should be the goal of every physical therapist, is for this particular case or person, of course, this individual, I'm trying to get you where you need to go as fast as possible, basically thinking about this goal of putting myself out of work with you. Yeah. It's not like, look, people are always going to get injured, right? So there's always going to be work for physical therapists.
Steady supply.
Look, but that's what I'm saying is, like, on an individual basis with you, I'm trying to put myself out of business, because that means I did my job and we were successful.
Yeah.
And that I get more out of that than seeing you for 3, 4, or 5 months. If I like you, I don't want to see you that much.
Yeah, exactly.
You know what I'm saying?
Yeah. I don't want to put up with you any longer.
Yeah, I know. This is rough already.
But it's a great lesson, though, when it comes, we talk about it in jiu-jitsu all the time. Earlier is better.
Earlier is better.
If you don't want to get, if you don't want, how do I defend the triangle? Well, don't get in the triangle. Don't get in the triangle. But but the earlier you defend the triangle,
get out of close guard.
Yeah.
Before you get into the triangle. So that's kind of what we're thinking about.
Yeah. So it's trying to identify things ahead of time that might predispose to these problems is definitely a part of it. But then, the problem does show up, and we have different types of shoulder problems that we can encounter. There's so many. I don't think we're going to be able to hit on just about all of them, but I think when we think about shoulder pathology, one of the first things that come to everybody's mind is the rotator cuff. Mm-hmm. So having rotator cuff pathology is almost ubiquitous to getting. Going through life, most everybody has some sort of involvement of rotator cuff pathology. Yep. As we get older. I'm 51, and so I guarantee you right now, if we were to take a look at my rotator cuffs, my supraspinatus, infraspinatus, we're going to see some ugly stuff on the MRI.
And that's the MRI play. That's right. What I always tell people, not just with shoulder stuff, but also with low back stuff. If you see stuff on the MRI, don't take that as a guarantee that you need to get under the knife.
Yeah.
And that is so common, where, like, the first few interventions that are presented to you if you are that person that has a back or shoulder issue is like, now we need to either do something invasive of putting a shot in, and don't get me wrong, they help to an extent, right? They help in certain scenarios, but they don't help everyone. They're not helping to the extent of them supplying it at the rate that they are supplying it as, especially also going under the knife for a surgery. Just because you have tearing in your rotator cuff muscles, or if you have a labral tear in the shoulder, or if you have a disc bulge in your back, that doesn't mean that the best intervention for you is a surgery, especially because of the fact that even after the surgery, then you have to, treat also the fact that you had the surgery, not just the disc bulge and stuff like that, or the rotator cuff tear. You also have then extended recovery time because of the surgery and what all comes with it. So I can't tell you how often during the week I say that to people I work with, that the MRI is not what we say it is in terms of the end all be all when it comes to what your treatment should be like. If you have a tear in those muscles, or if you have a disc bulge, if you have to have most of the time physical therapy anyway, why wouldn't you try 1 or 2 sessions before you go down towards a surgery?
Yeah, it's a tricky thing, because I think people see those MRI. The MRI the imagery is powerful. So you see the MRI, you see the tear. The doc points out the tear, he circles it and says, this is what's going on. And what's always missing, and I always tell people this when we're looking at research and statistics and clinical data, is that the scariest thing you'll get is the numerator. You'll always get, it's always scary to hear the top number in it. But if you understand that, yes, you have a rotator cuff tear, but so does just about everybody else. The denominator is what chills people out. If you say you've got a rotator cuff tear, okay, that's the numerator. If you say you've got a rotator cuff tear, but so do 80% of your cohorts at your age and they have no symptoms, well, that's completely different. And so I think as a medical community, we're getting a little bit better at communicating this data, because even surgeons who benefit from doing the surgeries know that not everybody gets better when they have surgery. So I believe they're trying to do a better job at picking their patients.
Now more so, yeah, for sure.
Which is, at least now, more so than 15, 20 years ago when I first started practicing, whereas if you had a tear in anything, you were getting it repaired. So now they're screening people a little bit more, which is good.
Yeah.
But, knowing that most of the time these tears and these things can come up even in a completely asymptomatic or non-painful population is helpful to understand. Now, that doesn't mean we can't still do things to address the health of the cuff and the strength of the shoulders and mobility. And
not to say that the MRI is useless, right? That's not what we're saying. Right? It's exceptionally useful, but it doesn't determine what your functionality is. And that's the big thing, is what are your functions right now with this going on? What were they before? And can we get you back to all of it? And that's not that I don't use an MRI to make that decision. I use it to have additional information, but it's not going to drive what I'm gonna, suggest or think about your results might be.
For real. Another interesting thing that not a lot of people we don't talk enough about is that if you were to take 2 groups of folks and you have one group that has rotator cuff surgery and another group that is the control or gets rehab or nothing, and then you track them over a period of time, usually after about a year to 2 years, both groups are doing about the same.
Mm-hmm.
Both the same types of tears. One gets surgery, the other doesn't. Usually the surgical groups do better early on, and then they all sort of regress to a mean over a period of time.
Yeah.
So it's not to minimize the effect of surgery. It's just that surgery doesn't always become the fix that we wish that it would. The real kicker, and the one that was always amazing to me, the data of rotator cuff failed rotator cuff repairs over the course of 5 years. The failure rate in rotator cuff repairs is incredibly high, regardless of whether you have rehab afterwards or not. But they're still doing well. So you can have a failed rotator cuff
Yeah.
and you're still doing okay.
Yeah.
You know, so it's a tricky thing, but I still think it goes back to making the case for whether you have a surgical repair or not. If you do the conservative route, trying to get good rehab.
I guess, I see what you're saying. Yeah, that's a good point. Yeah. Because you can have the basics done. You can get your range of motion back. You can get your basic strength back. But then when you're talking about people and returning to the previous activities, that gap that's sometimes missed is crucial and will set some people up for success and some others for failure.
Yeah.
Yeah, that makes sense.
Yeah. Getting the range of motion back, getting the basic levels of strength is a big part of the early rehab. But that needs to continue, and that's, I think, like you mentioned, there's a gap there that happens, and I think that's where staying active outside of the gym, outside of the jiu-jitsu mats, is really, really important. That's why I try to recommend people trying to stay in the gym. Resistance training 2 to 3 times per week, as much as they can, or as much as they're able to. Trying to keep as healthy a weight as they can manage, doing those things makes a difference when it comes to these types of things. So what type of rehab are we looking at for rotator cuff pathology?
I try to stay away from giving. Are you asking like time estimates?
Yeah.
I'm trying to stay away from time estimates.
Okay.
I always say the same thing typically about, looking at around a year for you to feel like you didn't have an injury before.
Yeah.
Now, there's a lot of gray area in between that, and I will say most of the time I will recommend at least looking at 3 to 4 months of modified activities and proper rehab, and then it's kind of depending on how their functionality is, how much more time they need, and how ready they are.
That's funny that you say year. That's what I say.
That's what you say.
Well, yeah, it's the weirdest thing. About a year.
Yeah.
And it does take about that.
But sometimes I don't even like to say that, because there's so much ambiguity in that. Because what does that mean, get back, or what does that mean, being normal again? So it's really just so hard to say. It's like, I rather them ask me a particular activity, when can I do this, and then I don't even give enough time frame. I usually give them markers to hit. So let's say, when can I go running after an ankle injury or whatever?
Yeah.
It's when you can perform a single leg quarter squat, when you can hop up to 10 times on one leg, when you can do 25 single leg calf raises. I'm giving all these things that I've noticed that they're deficient in, and I'm saying, okay, if you can hit that, then we got this. Then when you hit that, we got that. And then when you hit this, then that, and then you're ready to run. Right. That's what I like to do, rather than give them a time estimate.
Yeah, and for me, it's both. I think, you say, these are the performance criteria that you need to hit before we hit this, before you're back to running, before you're back on the mats. And I think that should probably take. I always like to pick a holiday.
Yeah.
I say by July 4th,
nice.
You should be able to do this. By Christmas, you should be able to be back on the mats,
That's
maybe rolling with some kids.
Yeah, I like that.
And that way they can kind of, okay, that. So as you say 6 weeks, and it's like, I don't know what 6 weeks is.
That's true.
But if but then if I say, oh, okay, by Labor Day, you should.
Nice. Yeah, I like that.
And or Memorial Day in this case. But yeah. So and then the rehab process itself can be really variable depending on the type of shoulder issue that you're dealing with. Typically, younger patients who don't have significant mobility deficits, the process is not as involved as an older patient with mobility deficits.
Yeah.
Mobility deficits, for me and the patients that I've seen over the years, addressing stiff shoulders is one of the biggest challenges in the clinic. And so if you have a sore shoulder and you've been able to maintain your mobility, most of the time the recovery process is pretty straightforward. Yeah. If you have a shoulder problem and then you develop stiffness in the shoulder, it's a horse of a different color. It takes a little bit more work to get better.
Yeah. And I think we can, and there's so many things, like we're obviously talking about the shoulder, but the shoulder is so complicated. It has so many different things that can happen that are impacting a certain activity. Like you said, the shoulder stiffness, adhesive capsulitis is even different than just shoulder stiffness, joint dysfunctions. You have your AC joint, which is critical, super important. Muscle imbalances, is AC joint separation. I mean, you name it. We can do a whole segment or a few segments on shoulder pathologies.
We should talk about the AC joint for a little bit because I think it's an interesting one. The AC joint is a joint that's on top of the shoulder here. And so usually if you've been training jiu-jitsu for any period of time, you just started learning how to Granby. Granby is one of my favorite examples. People will say, oh, both my shoulders, the tops of my shoulders are hurting me. And then you watch them Granby and you can see they're they're doing the Granby like on the back of the neck.
Or for people who don't know what Granby is, it's the inverting. It's the going onto your shoulder. It should be going on your neck, right? You should be pointing that out. You should be rolling from across your shoulders. Yes, your neck has a little weight on it, pressure on it, but you should be transferring the majority of your weight from one shoulder to the next as you're going around. Yeah, I can't tell you how many times I've helped people with their AC joint pain in jiu-jitsu by just helping work on their invert, and their invert mechanics. So just have them lying on their back, their feet up over their head, and making sure they're not putting pressure over the top of their neck or really putting pressure over their shoulders. So more like you're saying, more like the thoracic flexion. Is that what you're saying? Yeah. Really trying to, so that, when you invert, you should be able to lift your neck up off that. So you should not be putting pressure. Yeah. So you shouldn't be bending over your upper your cervical spine, which is the upper neck portion. So what you're saying is like between the shoulder blades, that area needs to become flexible so that they can open up there so that there's more of a fluid transition. Is that what you're saying? Right, yeah. So, I mean, it's just and it really helps because most of the time what happens when you invert is you'll get stacked, especially if you get, That's why I don't invert, dude. Like the guys I go against, man, fuck that. Yeah, I mean, it's definitely a risk. And so I got Donkey Kong the other day by Blair. Shout out Blair. Who knows what's going on at your gym? The 10th Planet stuff, Donkey Kong, all those terms. Donkey Kong is not a move. It's just it's the only way I can describe what this man did to me, man. He just had a double underpass. And he picked you up. He didn't mean to. I know he didn't mean to, but he just he kind of he did a really nice tight double underpass. And then when he pulled me in, dude, I went up off the ground, dude. I was just like hanging. You're not a light kitten either. Thanks. Anyway, and he dropped me back down, dude, and I was just right on the back of the neck. And I mean it was fine, but definitely tweaked my neck and made me be very, very aware of making sure that when I'm on my shoulders, I really don't want to be on my neck. That's right. And so for the inverts, I think that's a really nice way to show how technique can make a big difference in how much your shoulder or any joint has to deal with. I didn't think about the AC joint during the inversion. That's an interesting point. It's happened, I think, about in 3 different cases over the last 5 years. Man, both my, the top of my shoulders really, really hurt. And it's usually the little guys, and they've been doing a lot of inversion stuff. And then, training against me, a bigger guy, and I'm stacking them and smashing them. And so yeah, it's a problem for them. Yeah. All right, man. Yeah. I think we're getting to a good end. Obviously, like I said, we can talk about the shoulder way more, which we will. And that's where you guys come in. So if you want to have different topics on the shoulder, let's say, for example, you heard us talk a little bit about the rotator cuff. If you want more of that, let us know. Obviously, there's the labrum, which is totally different, and then has a bunch of other perspectives and variables we could discuss. So anything that comes injuries, to I talk about injuries that are coming up. Man, one thing we should talk about next time maybe is Mika Gavales. Knee injury, man. We'll have to talk about that and what's going on there. That's a very interesting mechanism of that injury. So and lots of things we could talk about, folks. So just comment, send us an email on physioplata@gmail.com, or just type it into the comments. Whatever you guys want to do, just let us know what you guys want us to cover, and we'll do it. Till next time, folks. See ya. Later, guys.